I'm very happy to be part of this webinar. I think it's a great event, and I, in particular, would like to thank Professor Bura for providing such a perfect introduction to my presentation. And I guess there will be a bit of material that is somewhat repetitive, but I think what we'll see now is what the implications of these demographics are in the setting of a surgical center where we have traditionally done a lot of transplantation and resection. Over the years in New York at Mount Sinai, this has been the distribution of liver diseases that we see. As in most of the Western world, hepatitis C has been predominant among the etiologies. New York is a community with a large immigrant population, maybe over 1 million Asian patients born in Asia living in New York. So we see a lot of hepatitis B. And over the years, NASH and alcohol have not been the predominant etiologies that we've had to deal with. Having this population of both hepatitis B and C in the same institution allowed us to do a comparison head-to-head of the outcomes between these two, and we presented this a few years back. The first thing is that according to the same criteria for selecting patients for surgery, resection versus transplant, patients with hepatitis B were overwhelmingly selected for resection because they had better liver function, whereas the patients with hepatitis C predominantly had liver transplantation. The results of resection, this is in 2014 that we presented at our American Surgical Association, showed a substantially better outcome for resection of patients with hepatitis B than with hepatitis C. The results of transplantation were similarly and almost the same, to the same degree, better for patients with hepatitis B than for hepatitis C, whether viewed from the time of transplant, as you can see on the left, or intention to treat from the time of listing on the right. The differences with resection had to do with both a higher rate of recurrent hepatocellular carcinoma and a higher rate of deterioration of liver function and decompensation, whereas in the transplant population, it was predominantly the result of hepatitis C infection of the grafts that led to reduced survival in those patients. Even when we look at the patients within Milan criteria for resection or transplants, these differences persist as significant differences back in 2014. It's been long known that treating hepatitis B with antiviral agents improves the outcome. It prevents cancer in patients who have not had it. And as shown in this study, in patients who have had hepatocellular carcinoma who are maintained on antiviral therapy, the incidence of new hepatocellular carcinoma is reduced by hepatitis B therapy. And the study that I just presented in 2014 was of a population where hepatitis B was already being routinely treated at that point. Basically everybody coming to Mount Sinai with the hepatitis B hepatocellular carcinoma was treated with antiviral agents, whereas it was just before the introduction of the direct-acting antiviral drugs for hepatitis C. I hardly have to present data concerning the treatment of hepatitis C these days. The drugs that came onto the scene starting in 2014 reliably cure hepatitis C. This is very clear, and even looking back in the interferon era, when patients were cured of their hepatitis C, it reduced the risk of hepatocellular carcinoma in patients who had not had cancer, as well as, I didn't really see a study looking at recurrence, but it clearly reduced the incidence of hepatocellular carcinoma. There was the early concern after the introduction of these drugs that treating hepatitis C in patients with hepatocellular carcinoma might result in a higher rate of recurrence. This came from Barcelona, and it caused quite a stir in the field, but I think it's been pretty thoroughly debunked at this point. We were part of this large multi-center study in the United States that really showed that there was no association of direct-acting antiviral therapy with early recurrence of hepatocellular carcinoma. There was just the reduction in incidence and later presentation of de novo tumors. So I don't think that that's really a concern anymore. It certainly is clear that curing hepatitis C, while it helps, does not eliminate the risk of hepatocellular carcinoma, particularly in those patients with significant fibrosis. And so that surveillance needs to continue. But nevertheless, I think that the curing of hepatitis C with the reduced incidence of cancer, as well as the stopping the progression of cirrhosis, has big implications for our surgical programs. If we look at our results, these are Mount Sinai results that are not yet published, comparing the survival of patients undergoing resection for hepatitis C between 1988 to 2011, compared to those resected from 2012 to 2018, which really is encompassing the era of the introduction of antiviral treatment for hepatitis C. We could see a very dramatic improvement in the survival of patients with resection going for hepatitis C in the DAA era. The same thing we observe in transplantation. Our results with transplantation for hepatitis C-related HCC at this point are equivalent to those with hepatitis B, and it's the biggest development that we've had in the field to be able to cure hepatitis C. If we look at the national data, my partner Parissa Tabrizian put together this study of the UNOS registry looking at the patients with hepatitis C and hepatitis B-related HCC undergoing transplantation, dividing them into the pre and post direct-acting antiviral eras. We see the same thing. In this study, it was a large number of patients, 30,000 patients with good numbers, obviously more with hepatitis C than hepatitis B, undergoing transplantation. The results really came out almost exactly the same as what our institutional data showed. This was before the direct-acting antiviral era. Hepatitis B had substantially greater survival after transplant than hepatitis C, whereas at this point in the patients transplanted in the more recent years, the survivals have become equal. So when transplant is necessary, the results are better. But what we've also noted is that the incidence of transplantation is changing. This is national data, and you can see that a peak in 2015, a number of patients were transplanted in the United States with hepatitis C-related HCC, that's the orange. And since then, it's been falling. And this, I think, is clearly the result. Well, it's the result of two things. Primarily, that patients with hepatitis C don't need transplant to the same extent that they did. Also, the rules for determining organ allocation in the United States have changed to deprioritize hepatocellular carcinoma, and we'll talk a little more about that in a bit. At Mount Sinai, we've experienced the same thing. The changes in organ allocation have led us to do more transplants than we used to, but the proportion of the transplants that we do at our center has fallen from a high in 2014, when 57% of the transplants done at Mount Sinai were for patients with hepatocellular carcinoma, down to the more recent era when it's just a third of the patients going for transplant who have hepatocellular carcinoma at Mount Sinai. Interestingly, the resection experience at our center has paralleled this. We are seeing fewer patients going for resection. My impression is, and we've been working to study this, that we're seeing less hepatocellular carcinoma in the setting of hepatitis B in New York. My sense is that this is probably because the population of Asian patients in New York have been on antiviral therapy for the past 10 to 15 years pretty consistently, and we're seeing fewer cases. We're certainly seeing fewer cases of recurrence of hepatitis B-related HCC than we used to. It used to be pretty much every office session in the Chinese community where we have offices, we would see a patient or two with recurrent hepatocellular carcinoma. Now it's a rarity. But I think it's also related to the decrease in hepatitis C-related HCC and the fact that we're seeing more patients with etiologies that maybe aren't so suitable for resection. We're coming onto the same epidemiologic data that we just heard from Professor Bura, that while the hepatitis C-related HCC incidence is dropping, that's the dotted line here at the bottom of the graph. Statistical models, whether looking at linear or exponential growth models, show that steatohepatitis-related hepatocellular carcinoma is really on the rise for sure. Looking at our Mount Sinai data, just new hepatocellular carcinoma cases presenting with a diagnosis of NASH, you can see that the incidence is rising. I think we, and I imagine many centers, have an issue trying to dissect out the etiologies, and we like to label our patients as having a particular disease. Our patients in New York with hepatitis tend to come from a community where there's a high level of obesity and diabetes, also a fair bit of alcohol. If a patient has a positive serology for hepatitis C, then we tend to label them hepatitis C. But I think that, in fact, many of these patients have a mixed etiology, which makes it a little difficult to sort out things when you try and present these data. But clearly, patients with pure NASH and nothing else are on the rise. If we look at our overall population, on the left here, you can see the distribution. I showed this before of our overall experience compared to the experience in 2019. We could see that we are seeing a substantially smaller proportion of our patients with hepatitis C. Hepatitis B hasn't changed that much, but we're seeing a large increase in the patients with NASH and with alcohol-related HCC in the current period now compared to our overall experience. If we look at the patients just going for resection, the difference isn't so great. There's a higher proportion of NASH patients, but it's not at the level of what we've been seeing overall. Alcohol, we don't see an increase in patients with resection who have alcohol as their underlying disease. We just heard about what we know that fatty liver disease can cause hepatocellular carcinoma without cirrhosis. And we generally think of patients with HCC and no cirrhosis as being good resection candidates. But we've looked at this in our experience. We presented this a number of years back. And while it's certainly true with hepatitis B that the results in non-cirrhotic patients are excellent, we did not demonstrate excellent results in resection of patients with NASH-related HCC who are non-cirrhotic. This has to do partly, as was mentioned before, that these patients tend to present at a late stage, and partly because the patients tend to be physiologically not necessarily optimal candidates for surgery, often with obesity and other risk factors that can impact their survival. So that NASH does not appear to be a setting where resection is an optimal treatment. This national study demonstrated that steatohepatitis is the fastest growing cause of hepatocellular carcinoma in patients going for liver transplantation. And we've seen this at our center as well, for sure. This is the Mount Sinai data. The proportion of patients going for transplant with hepatitis C, you can see is getting to be almost half of what it used to be, whereas the proportion with alcohol and with NASH has expanded quite significantly over the recent years. we're concerned, based on our results, this is a national study that seemed to demonstrate that patients undergoing liver transplantation for NASH-related cirrhosis with or without hepatocellular carcinoma don't tend to do as well as patients with other etiologies. These patients, as was mentioned before, are older as a group. They tend to have comorbidities. NASH is one manifestation of the metabolic syndrome that also is behind the leading causes of death in the population, cardiovascular disease, and so forth, with diabetes. And so it's not surprising that results would be perhaps worse in patients with NASH undergoing liver transplantation as compared to other indications. There is the information that we know, this is an era where we're doing a genomic analysis in cancer regularly. And I think I've always thought as NASH as a condition that's really behavior related due to obesity. Certainly there's a genetic element that patients with NASH truly just had a single manifestation in the liver and just as likely have all the other manifestations of diabetes and heart disease. And so that in that sense, they're not necessarily good candidates for surgery of any sort. But I think that understanding the genomics and the fact that there are patients who are predisposed to steatohepatitis, particularly without necessarily having all the other manifestations of metabolic syndrome, is important. I think we may have to start sorting out our patients. In our population here, we have a huge number of people coming with hepatocellular carcinoma now and NASH, and for the most part, we are treating them non-surgically these days, but I think we have to start looking at this group that has this particular predisposition to cancer. This is data similar to what was presented about the incidence of this type of mutation that tends to lead to steatohepatitis and cancer around the world. In the United States, it's sort of in the mid-range, and it's been demonstrated that patients with this type of a genomic picture with the PNPLA3 mutation, while they have fatty liver and hepatocellular carcinoma predisposition, actually have a reduced incidence. This genetic alteration is protective against the manifestations of NASH, of the metabolic syndrome, really, on cardiovascular disease. They do not have the same incidence. And so that I think we're going to have to look at this population of NASH patients and understand the ones who have a selective liver predisposition as opposed to the entire body being the result of the overeating and lack of exercise as the population who are going to be the target for things like resection and transplantation. So to conclude, I think that the reliable cure of hepatitis C has resulted in better survival for patients who go for surgery, both for transplant and resection. There are more patients who are eligible for resection, and the priority for transplantation in the United States has been reduced, because I think what's recognized is that many of these patients now, without the progression of cirrhosis, without the high incidence of recurrence of hepatocellular carcinoma, can be treated either with resection or non-surgically. And I didn't go into this, but we're doing a lot more primary treatment with microwave ablation, or at our center, radioembolization. Targeted radioembolization is viewed as a curative treatment that we use quite a bit. Has been the destination, the primary treatment for patients with early hepatocellular carcinoma rather than transplantation. And NASH, we know it's increasing. It's related to obesity and diabetes, but also to genetic factors. And I think we need to really start paying attention and understanding this to the extent that we are doing in other diseases, like in cancer, where genomics is really have such a major influence on the field, in order to better select our patients when we're thinking to apply surgical treatments. Thank you.